comprehensive pain center that we have here at UConn. Today we are doing a third talk in a series of 6. We do each of these twice in the morning hours and in the evening hours. The other 2 you can find at our website that is listed below on this slide. Today we're talking about where do we go from here, best practices and reasons for opioid tapering. I'm actually really excited to do this talk because I think this is a skill set that we just don't learn during our training. I'm going to turn it over to my colleague who can introduce himself.
Good morning, I'm Kevin Chamberlin. I'm a clinical pharmacist with pain expertise and proud member of the Connecticut Comprehensive Pain Center. Together with Dr. Andrews, we work together with a primary care physician, Dr. Jen Ozimek, and our addiction psychiatrist, Dr. Sarita Rao, and we round out the entirety of the Connecticut Comprehensive Pain Center. We're going to actually go off camera to allow for the best transmission of sound, and then we'll come back on for Q&A at the end.
So as we head into our talk, we just want to let you know that these sessions were made possible by grant support from the Connecticut Department of Public Health. And today we're going to focus on identifying appropriate reasons for tapering, understanding the methods of tapering through some patient examples, and also how to manage the withdrawal symptoms with the use of adjunct medications. We do have 2 cases to walk through, one that is a bit simpler but probably what you see more often, and then one that is more complex that does address that this is not always something that is easy to do. We know, and we've discussed in our other 2 presentations, how complex pain can be, and we just want to run you through some slides touching on some aspects that we might not have had the opportunity to delve into completely. So I know our other talks discuss treatment of coexisting conditions, but we wanted to remind you just how complex pain can be. In order to treat it appropriately, there are reasons that you need to screen for other mental health conditions, such as depression, anxiety, and pain catastrophizing. The reason you need to is because treatment of each of these individual mental health conditions actually improves pain outcomes, even if you're not using medications that are directed to pain. We listed some screening tools here on the slide for you to use. We also want to talk about sleep and pain in the coming slides, but for now, suffice to say that it is a bi-directional relationship with each affecting the other. And then the last thing that we'll say on this slide is you need an accounting of your patient's resources, what their support system is, what their culture is, especially in reference to pain, in order to be able to treat them as comprehensively as possible. Most pain management will focus on physical injury, and we have also talked about how to identify the actual cause of the pain, but this pictorial gives you an idea that each of these components goes into a patient's pain. And for each different individual patient, any of these circles can be larger or smaller, and identifying which of the ones are the highest or most impactful for a patient's pain will help you address those and get better results from a pain management standpoint. We've also discussed functional goals, especially at the time of initiation of opioid therapy, but what we haven't talked about is asking your patient how they would define success. Would it be a 30% reduction of their pain or 45%? Is it more of an increased activity, working an 8-hour workday, or actually being able to sleep at night? As a prescribing physician, sometimes I lose sight of this as a patient's initial goal, and this is really your target that you're treating to. Sometimes we get a little overzealous, and I'll include myself in that group, trying to gain even more pain relief, even though we've hit that mark that the patient has set for us, and that can cause us to increase or add on medications, increase doses, and then increase side effects as well. This is a slide that you can find that we go through in detail in a previous discussion, but we wanted to highlight that pain treatment is multimodal. So the therapies that you see on the left are those therapies that should always be in use regardless of the pharmacotherapy you're using. You can alternate between these depending on which ones seem to work better, and we'll touch on a few of these today just with some evidence to which ones are most effective. Currently, a lot of the items on the left do have an out-of-pocket expense for your patient, although some of them you can use healthcare dollars for. Those on the right, this is just a listing of the categories of pharmacotherapy that you have at your disposal to use for your patients. So reiterating some of the points that we discussed in our previous talk, tailoring your pain management to the patient in front of you and their cause of pain is really important. Pain management should be intentional, both at the start and the end of certain medications and therapy. Most medications, whether it is an opioid or a separate medication, at best will reduce your patient's pain by 30%. So that's something to keep in mind, especially as we've gone over that there are a lot of myths surrounding opioids that they are stronger. When you take that and compare that to the numbers that are listed below for treating those concurrent mental health disorders, you can see why we suggested screening at the beginning. So by improving and treating someone's depression, you get a 45% reduction in pain intensity, even though you are not using a medication directed at pain. Similarly, if you can get a patient to stop with the behavior of pain catastrophizing, you can decrease their pain by 33% simply by adjusting that. So thinking back to what we just spoke about, if your patient's goal is to reduce their pain by 30 to 40%, you can get that before you ever treat their pain with an intentional medication. Not unlike the previous slide, the topic of sleep and chronic pain is more in depth than on the surface. So obviously, if you have pain, you might not sleep that well, but sleep disturbance itself can also affect patients who have chronic pain. It causes more symptoms for a longer time, that are also more disabling, and in and of itself, it can be associated with additional mental health conditions and exacerbations. So just like treating depression can decrease pain intensity by 45%, properly managing sleep conditions will improve pain outcomes. And this is why screening for things like insomnia or sleep apnea is just as important as screening for depression. So looking at some of the other tools that we have outside of medication, I want to first talk about CBT, which is cognitive behavioral therapy. CBT, when used for pain, is a little bit different than just when it's used for any other condition. It works on both pain and sleep. It's actually first line for insomnia. It's been shown to reduce relapse in patients who have chronic pain with exacerbations. It helps reset the patient's pain belief system and helps them adjust to what are reasonable goals. And the best news is it's a finite number of sessions, 6 to 8 sessions for an hour or two. There's tons of flexibility. It can be done online or in person, group or individual. While CBT helps with your pain belief system, it also improves distraction and coping mechanisms in a way that mindfulness does not, but mindfulness is also helpful. Patients can again learn to do it in 6 to 8 sessions that are about an hour or two each, and it helps them learn to manage their negative thoughts and feelings. I know we all send our patients to physical therapy, but I want to explain why. The active engagement that is done during physical therapy can be transitioned to an active lifestyle with exercise, and that's where we really get the benefit for pain management. Massage and other passive physical manipulations help short-term, but those results are simply temporary. And then moving into medications, our other talks went into more detail on the different medication categories that you have to use for pain. We just wanted to put the key points up here and realize that you have to go over the risks and benefits of each. Targeting the most appropriate dose for acetaminophen is important. Also making sure that you're utilizing the subclasses of NSAIDs. So if one fails, they haven't all failed. And then a reminder that muscle relaxants have a limited benefit, use for a short time only.
So now that you have a reminder of what's in your toolbox, we're going to make a brief stop and talk about acute pain and to tie things together from our previous talks as we transition to taper discussion. Even in acute pain, you need to set expectations for pain relief and expectations for medication discontinuation at the start of therapy. You want to treat it because undertreated acute pain can become chronic, but as you'll hear us say again and again, you want to be intentional with your plan, both in treating the pain and with de-escalation of therapy. Remember, opioids are not a cure-all. The probability that a pure mu opioid receptor agonist will actually achieve a 25% reduction in pain without causing respiratory depression in a drug-free, healthy adult is about 70%, according to a study from anesthesiology in 2018. In other words, you have a 50-50 shot at getting up to a 50% reduction in pain. And the mean relief achieved in this study, it wasn't over 40%. A summary of the steps you need to take before prescribing opioids are listed here. So identify and treat mental health conditions, screen for risk of addiction and overdose with any of the tools that we showed you in one of our previous talks. Identify other high-risk medical conditions such as sleep apnea to limit harm. And the last consideration, society, is actually best represented on our next slide. In considering the effects of opioid prescribing on society, we have to look outside of the one patient that's in front of us. In 2015, nearly 100 million Americans were prescribed opioids by the doctor. A recent survey showed that a third of people who abused prescription pain medication in the past year got pills directly from a physician. This abundance of pills impacts the community at large when excess pills are sold, stolen, or simply given to others. In fact, receiving painkillers from a friend or a family member was the most common gateway to abusing opioids. Call it the friends and family plan, if you will. This slide shows more opioid misusers receive their medications from a friend or a family member than a physician, 38 versus 34%. So when you do prescribe, use only the necessary number of pills is important. These should be familiar. These are cutouts from the Hopkins guidelines. Not all acute pain requires treatment with opioids. A major barrier to appropriate dosing of opioid analgesics is that it's difficult to predict the intensity and duration of pain after an injury or a surgery. Pain varies depending on the type of injury or the surgical procedure, patient demographics, cultural or ethnic factors, a prior history of alcohol, drug, or opioid use, and the history of anxiety or depression. So now, putting this together with what we know what many people do with their, quote, extra medications, specifically in acute pain, we should be prescribing a limited number of pills with a clear description that does not include simply to take it PRN. So for example, the first 2 days out of surgery, schedule the dosing maybe as Q6 hours, and then begin the de-escalation and go to Q8 hours for 1 or 2 days only, and then Q12 hours for 1 or 2 days, and then once daily or even done. Hopkins also created dental recommendations, and these suggestions are really important for our teens and our young adults, as these are opportunities that these patient groups are potentially first introduced to or re-exposed to opioid analgesics. So now, having seen those Hopkins guidelines again for duration of use and quantity prescribed, now it's going to make clearer sense. The reason we spent so much time about short-term prescribing is highlighted right here on your screen. Almost all the guidelines will say less than 7 days in acute situations or as a first trial for pain management. As you see here, at about 5 days, the likelihood of dependence increases. And note that 3 years out, nearly 25% or 1 in 4 patients prescribed opioids are still on them if given a 1-month supply at the initiation of therapy. Multiple studies have shown that excessive opioid medications are routinely prescribed for all types of surgical procedures, as well as after emergency department visits for painful conditions, and most patients actually save those leftover pills. As a result, large amounts of opioid tablets are available for diversion. So here's 2 examples. out of Michigan. Higher prescription quantity was associated with higher patient-reported consumption, though a causal relationship couldn't be confirmed. Secondly, a study involving 250 patients who underwent upper extremity surgery reported that most patients received a prescription for 30 opioid tablets. 77% of the patients took half or less of the prescribed pills, and 45% took actually less than 5 tablets. The total number of unused tablets from these 250 patients, 4,639. So in finishing this first section of our talk today, it'd be helpful if you haven't already to go back and review our previous 2 talks for a more in-depth review of how to approach pain. They're both posted here on the slide and linked on our website as well.
I just wanted to summarize some of the limitations that we have with pain management. We hope that the intro has brought you back to the details that we've talked before and some new ones. So the most salient points I think that I would want you to remember are any medication has limited pain reduction, including opioids, about 30% for any one. There's significant risk of side effect, including respiratory depression, when using opioids and trying to get greater than a 50% pain relief. We talked about the significant benefits of treating depression, sleep disturbances, and pain catastrophizing without any analgesic-directed interventions that is essentially equivalent to using one medication for pain or better. We just saw a slide that showed that unintentional long-term use happens with opioids when given too great a prescription at the start or refills. And finally, overprescribing opioids can have effects on the patient, but also their circle of friends and family. So that brings us to a little bit more challenging of a question is, what are the opioids' role in chronic pain? We did have a whole talk that talked about the treatment of chronic pain, but just for this, it's not different when you look in the research than acute pain. In fact, a Cochrane database that was from 2010 showed at best, opioids had a modest effect on pain and really no substantial improvement in physical functioning. And just to be explicit, so we're all on the same page, 50% or fewer benefit from their opioid for pain at 3 months, and 12% or less benefit at 6 months. So we see people maintained on opioids for years and even decades, but when you actually look at the data, it is not supportive.
If we ignore time of prescribing and just look at dosing, the literature shows that a dose of 35 morphine milligram equivalents is the mean effective dose for pain. A case series found the same thing, with the cutoff being less than 40 morphine milligram equivalents for effect. And evidence from an observation-based study found a 9-fold increased risk of overdose at doses greater than 100 morphine milligram equivalents versus just 20 morphine milligram equivalents. For each overdose death, there are more than 7 non-fatal overdoses. We'll come back to overdose risk in a moment. And if you're using the evidence, currently the low-risk meds perform at least as well as opioids based on the 4 studies you see here on your screen from 2010 through 2018. In summary, there's a lot of evidence against chronic opioid use as an effective analgesic option for chronic pain patients.
So I wouldn't say that we're saying don't ever use them. We just really want you and your patients to be aware of the risks, as well as the limited data, as we tend to practice, or hopefully tend to practice, with evidence-based medicine. So if you are going to use them, how do you reduce the risk? And really, the risk reduction starts the moment you decide to prescribe. Your patient should know from the start that there are reasons to taper them and a sort of guideline on timing for that. So if they reach their goal after having effective treatment for several months, remember the slide that said there really was a lack of evidence for long-term benefit, you should consider weaning them to see if the acute or treating that chronic pain with opioids for a short term has allowed lower risk medications to do their job. So consider a taper then. Or if they fail to reach their set goal, be it their functional goal or their pain reduction goal. If they have an adverse effect, they should be tapered. If they have an intervention for resolution, such as surgery, they should be tapered. And I caution you to be careful that we're not continuing opioids for other pains that haven't had a full workup and that haven't tried lower risk medications. And then, of course, the negative reasons that we think about, such as diversion, they should be tapered at that time as well. So it's like having an exit plan. Every plane that takes off should have a plan to either land at its destination or detour. Your patients should be educated on the aspects of opioids that really, I think we fail to talk to them about with each individual patient the way that we should. So hyperalgesia, we need to explain to them that by putting them on an opioid that they might have a belief is a strong pain medication, we actually run the risk of increasing their pain. And if we're using it above doses that we just talked about that are in evidence, that risk actually goes up. And when is the last time you warned your patient about urinary retention or the onset of chronic abdominal pain or gonadal suppression from their opioid? Often we use opioids when we're frustrated, us or our patients or both of us, with a lack of pain reduction from other treatments. And these tend to be the harder to treat conditions, the chronic abdominal pain, fibromyalgia, etc. But the evidence for opioids in these conditions specifically is even more sparse, and the treatment guidelines are against using them. There's also a recent study that discusses the development of depression and anxiety in patients using chronic opioids. And on the flip side, the euphoria of opioids may treat their depression if they have a pre-existing depression enough that you miss diagnosing it. So just going back to what we said at the beginning, by missing that diagnosis, you've missed an opportunity to treat them in a way that can reduce their pain by 45%. And then lastly, there are population-based studies that actually show poor quality of life, physical function, and pain control for patients who are on opioids.
Outside of lack of evidence for effectiveness, we have to consider the current opioid epidemic. The thousands of overdose deaths around the country are the most extreme symptom, but the problems run much deeper. In 2017, there were over 11 million quote, opioid misusers in the United States. That's the entire population of Ohio, or 4 times the population of Connecticut. The healthcare burden of the crisis is also staggering. The cost of the opioid abuse ranges from $10,000 to $20,000 in annual medical costs per patient. And the opioid epidemic is projected to claim nearly 500,000 lives over the next decade.
So getting back to what we talked about with overdoses, there's a study from the Annals in 2016 that showed even after a non-fatal overdose, clinicians continue to prescribe opioids. And I just want to go over the numbers with you for a second because it's staggering. 91% of those patients with a non-fatal overdose still received additional opioid prescriptions after the fact. 70% from the same provider who was writing the prescription at the time of overdose. Of those 91%, 7% had a second overdose. The patients in the 7% cohort tended to be on higher dose opioids or a concurrent benzodiazepine. So in summary, there's limited evidence for chronic opioid use. So if you are prescribing, we would ask or suggest that you really need to provide clear instructions and clear boundaries for your patients. So expectations of pain relief, again, we are not looking for a pain level of 0, and you have to explain to your patients that use of an opioid really is only going to get them about a 30% reduction in pain relief. Mild, tolerable pain that still allows a patient to function is actually a more reasonable expectation. You have to go over the risks of dependence and overdose, and you should be screening them with some tool, and we highlighted these in our second talk, to be able to discuss with them what their personal risk is of becoming dependent. You have to give instructions on how to take an opioid, how to take non-opioid medications, how to decrease them, how to stop them. Patients need to be educated that they shouldn't be on an opioid alone, that they need non-opioid pain medications to help reduce the risk of tolerance, and that opioids, because of their risk, should only be used when several trials of non-opioid pain medications have failed to provide adequate pain relief. And I'm going to just say I'm probably not as good at this last one as we should be. We really have to talk to our patients about safe storage, secure locations. Think of that slide that showed that friends and family will be able to obtain these medications. Excess pills need to be disposed of and disposed of properly to minimize this risk of diversion and inappropriate use. Patients should not be just keeping them in the house for a rainy day or if they have an additional pain, especially given the risk of overdose. There are take-back medication days, public safety center disposal boxes. Most police stations will have them. There are mail-back programs, gel inactivators, kitty litter and detergent containers, and we really advise that people not flush medications down the toilet. And then lastly, you really want to send your patient out of the office with written instructions that are in layman's terms. Now with open notes, they can read your notes. So just make sure your instructions on the risks and benefits are in a language that the patient can understand so that you can look back and know that you reviewed all of this with them. So tapers are easy to talk about, a little bit harder to put into play. Again, it requires intentional deprescribing, just like intentional prescribing. Each patient provides a different experience, a different interaction, a different set of hurdles, roadblocks, or uniqueness that you have to navigate. So we're going to walk you through several scenarios and approaches to tapering opioids. We're just going to give you an example of how to have the discussion first to give you an idea of what we're hoping happens in the office. So we'll start with a generic patient who happens to be 57 with a history of knee osteoarthritis and has a pretty physically demanding job. This patient has really done his due diligence. He's lost some weight. He's done exercise and physical therapy via aquatherapy. We have tried several lower risk medications, but he's still in pain and he's a sole income earner in his house. He needs to be able to do his job for the next 8 years until retirement, and he understands that that's the goal. So we start the conversation by addressing parameters, metrics that we'll measure or follow, and really being just explicitly clear. This medication is a trial. There's limited data on effectiveness, so we have to touch base to see how it's working. You should go over a med agreement with them. This is not legal, it's not binding, but it does go over reasons to stop the medications and what the risks are, and it's really good for you to have as well as the patient. You should talk about the fact that you're going to check the state database and what it is you're looking for and why multiple prescribers are dangerous, as well as additional sedating meds. Screen for the depression, anxiety, and opioid addiction risk for the patient in front of you. I think we went over that several times already. And you really have to set a functional goal and a pain goal and be intentional and stop the medication if those are not reached. So what does this look like when you see someone in the office? You might say, Mr. X, you completed multiple courses of physical therapy. We've trialed some low risk medications and really you haven't improved. I know that you need to work full time. I understand you're worried about supporting for your family. And I also know that although you're willing to have knee replacement surgery, the orthopedic surgeon wants you to lose weight before considering this. You've done great losing the weight so far, but you need to lose a little bit more. Let's go over the risks and benefits. This is a low dose opioid that we're going to start. I think it's appropriate, but we're going to use a 2-week supply and see how it works for you. I need you to understand at best, we may get your pain down from an 8 to a 5, which is a 40% reduction, and that's what the data tells us. And this medication will be stopped at time of knee replacement, or if you're having significant side effects, even if it's working to provide relief. If there's any signs of misuse or you're not reaching your goal, we are in those cases going to stop the medication as well. Oops. Hold on. I do think that we need to talk about one other item when it comes to opioid pain medication. When you enter into an agreement with your patient to start this high-risk medication, you just need to be aware that if for any reason they have to transfer their care, either because you're moving or closing your practice or they need to change a different prescriber, that person might not be willing to continue this. And so you have to have that plan as well. The CDC reached out after their guidelines and said, our guidelines weren't with the inclination that everyone was just going to suddenly cut off these patients with who were on opioids. We have to do compassionate deprescribing, which is what we're going to talk to you about today. You also have to just make a plan with your patient that if they are going to go from you to someone else, that you will be willing to taper them to make sure that they don't have adverse effects of the taper.
Opioid tapering can be a scary time for patients. Prescribers may be worried about their patient turning to illegal means for pain control or abandoning them in their pain management treatment. But tapering can reduce the development of tolerance and offer the opportunity to assess continued need of a high-risk med. Additionally, reasons to taper are varied and range from alleviating unacceptable side effects, reducing potential for diversion of medications, addressing the failure to reach a functional goal, and meet the desire for less risky medication use by all parties involved. Tapering should begin by decreasing dosing milligrams first, followed by the frequency of dosing once at the lowest milligram option. We'll go over this multiple times. If it's not tolerated, then we decrease to the lowest acceptable dose and then decrease the frequency if able. Choosing between a fast or slow taper. The biggest consideration to at first address is patient willingness, second perhaps only to patient safety. Items that might lead to faster tapers are listed to the left, inclusive of things like previous risky behaviors such as accidental or intentional overdose, suicide, diversion, or urine tox anomalies. Additionally, more rapid tapers may be necessary for those patients converting to treatment for opioid use disorder or even those headed for incarceration. Rapid tapers can cause withdrawal effects, and patients should be treated with adjunctive medications to minimize these effects. And at times, you may need to consider admitting the patient for possible inpatient care. If patients are prescribed both long-acting and short-acting opioids, the decision about which formulation to be tapered first should be individualized based on a medical history, mental health diagnoses, and patient preference. Data shows that overdose risk is greater with long-acting preparations. Slower tapers may be dictated by the list on the right. Need for changing to the existing regimen for failure to achieve, or actually even accomplishing that functional treatment goal. Additionally, concomitant high-risk meds could dictate a need for a more deliberate taper, using caution reducing one CNS depressant in the presence of others, given that maybe perhaps they might have an augmented metabolism or clearance in its presence or absence. I'm going to try to zoom in on this slide and give your eyes the benefit of the doubt. Tapering should generally begin by decreasing dosing milligrams first, followed by frequency of dosing once at the lowest milligram option, like I said before. And if it's not tolerated, then we decrease to the lowest acceptable dose and then decrease the frequency if able. Published evidence actually illustrates that success for patients on high daily doses and a willingness to taper is most successful. Many of the medications used to alleviate withdrawal symptoms like opioids need to be used with caution in patients over the age of 65. So let's put this into practice. Mr. Martinez, he's a 53-year-old post-operative male who underwent hernia repair 2 years ago and unfortunately suffers from chronic nerve pain in his abdomen from the surgical mesh, and the surgical revision didn't relieve his pain. His regimen's inclusive of gabapentin 300 TID, morphine extended release 30 twice daily, and morphine immediate release 15 milligrams every 12 hours for a total MME of 90 milligrams a day. He comes to you and says that his morphine's no longer helping, he's severely constipated, which worsens his pain, and his gabapentin is maybe helping, but he didn't tolerate the higher doses because he felt out of it. His anxiety level has been high. He's angry and sad about his surgical outcome and struggles with his daily functioning. He had to retire early because he could no longer sit at his desk job or concentrate. He sleeps poorly, and his life has changed drastically since before the surgery. So again, he asks you for help with weaning the morphine and what to do with the leftover medication. The basic tenets of opioid tapering are first to individualize your plan. So you can go as slowly or as quickly as the situation permits or demands. You employ non-opioid analgesics to augment the transition off an opioid-focused regimen. And a good rule of thumb is a reduction that approximates about 10% of the original dose per week, but you also realize that in some, this may still be too fast. If you think substance use disorder is part of it, the best thing you can do for your patient and you is to refer, or even start Suboxone prescribing yourself. Now that you know the numbers and the data behind opioid limitations, you can provide encouragement as your patients taper while keeping in mind there could be a psychological dependence you may also need to work through with them. So remember, Mr. Martinez was on his current regimen, this current one up in the upper left-hand corner. One potentially semi-rapid taper done over 4 weeks is outlined here. The first week, we went through morphine and we just decreased the evening dose from 30 to 15. So he's on 30 and 15 of his controlled release, and we maintained the immediate release. Week 2, we cut both the morning and the evening down to that 15 milligram extended release, but maintained the immediate release still. But by week 3, we had him only on one extended release just in the morning, or the patient preference. Perhaps they'd want it in the evening, but either or, just one of them. But maintained the immediate release still. And then by week 4, you just have the patient on the immediate release, perhaps even down to just once a day, if at all. Another patient taper, and I understand this also looks busy, but I'm going to try and get you to understand what we did. So this is oxycodone based, but the numbers are the same. So oxycodone ER30 TID and oxy IR15 Q6. It's a very slow and deliberate approach, but there are potential things to pay attention to as to why this approach may be beneficial. Say the patient had failed previous attempts, for example. So here we decreased just one midday dose of the extended release during the first month and maintained the rest. Subsequently, in month 2, we also decreased the evening extended release dose. And in month 3, we got all 3 scheduled extended release doses down to the same 20 milligram dose and maintained and decreased the immediate release by 5 milligrams and held it there for a month. And then took a similar approach again during months 4, 5, and 6 by dropping a midday dose down, then an evening dose, and then the AM dose each respective month. So by month 12, the patient was then only on an immediate release regimen. And depending on actual PRN use that you monitor, you could map out the remaining taper. Sorry about that. Hold on. So here's an example for a post-op taper. In general, procedures and injuries that involve bones and joints are more painful than those that involve soft tissue. A number of studies have examined the degree of pain and/or the quantity of opioid required for pain relief after specific ambulatory surgical procedures to know the amount to send them home with. Most are single institution studies, and most do not report the use of non-opioid medications or analgesic techniques, things like local anesthetic infiltration or peripheral nerve blocks. Remember though, this is not a 20-tab prescription that you send home as take Q8 hours as needed. This is a take 1 tablet every 6 hours as needed days 1 and 2, then Q8 as needed, and then twice daily, tapering off realistically in that first week for most patients. Withdrawal comes with its own set of symptoms, even when conducting a deliberate taper. Patient empathy through the process is key. Please keep in mind that some patients will have prolonged symptoms, similar to how a patient being tapered off, say an SNRI or an SSRI, might have a lengthy withdrawal period. In our own institutional toolkit for prescribers, we've written up guidance to assist with managing their patients' symptoms as they arise. Here for autonomic symptoms, we consider clonidine as a go-to first-line agent. But remember, that requires blood pressure monitoring and should be evaluated pretty regularly, with a targeted duration of use for less than 2 weeks. An alternative could be baclofen, which may have the benefit of also decreasing cravings after withdrawal. Gabapentin, like baclofen, has renal dosing guidance, so we got to be aware of that. It's also similar to baclofen in that it has secondary benefits, this time as an analgesic, an anxiolytic, and a sedative that can assist with sleep disturbances. At the bottom of the slide, we list two antihistamines for consideration that have multiple effects, these as anxiolytic and antihistamine properties. For myalgias, treatment is as expected. Consider the utility of both NSAIDs and/or acetaminophen scheduled, or even topical agents that are aspirin or, say, lidocaine based. The remaining symptoms have straightforward options for consideration. Low-dose trazodone can assist with sleep, standard antiemetics for nausea management, and etc.
So I'm going to present another case. This woman, Ms. Bloom, has some psychosocial complexities that I think we see in our patients. They can be challenging when treating diabetes or hypertension, but they become a little more challenging when we're treating chronic pain and dealing with controlled substances. This was an unfortunate story of a 38-year-old female with a long history of knee pain after a sports injury when she was a teenager. She had been treated with a variety of medications, including opioids, for this as well as a genetic disorder. She had self-tapered over the years, but always seemed to return to her chronic opioid use, basically after multiple prescriptions from other physicians. So she had bronchitis, was given a codeine cough syrup, and that sort of tipped her over and she went back to using it, or acute injuries that she had. For this patient, one of the things that pops out to me that are concerns from prescribing physicians are the following. This was a young woman who'd been treated for a long time, but was started on an opioid at a young age. And we know that for people who are under the age of 22, they have a high likelihood of misusing opioids if started on an opioid for an acute condition. It was an opioid that was prescribed for a sports injury. There had been no physician-directed tapering, which is unfortunate, but the patient had tapered herself, which I think is good. However, she did sort of, for lack of a better word, relapse after an opioid that was prescribed a variety of different ways over the years, and you could follow her pattern. And she also had a fair number of high-risk concurrent medications. Mixed in with all of this is you could see that she had an opioid use disorder by her behaviors and by her admission. She had, been to a rehab program in the past. She had some concurrent medical marijuana, which is just concerning based on a substance use disorder history. There were legal issues, which were really her motivating factor for wanting to taper. And she currently wasn't working, although she was looking for work. And this just comes into play for a support system. So looking back, hindsight is a little bit 2020. Back when she was started 20 years ago on her opioid, we were really partnering with patients against pain. There was this huge movement to treat pain and eradicate all pain. We tried to get people to be completely pain-free. There was a lot of long-acting opioid use in addition to breakthrough opioid use, almost prescribed the same way you would with a long-acting insulin and then short-acting for meals. It was just the current mechanism and theory at the time. There was less concern for concomitant sedating medications at that time. And really, opioids were used very often with teens for dental procedures. And we now know the risks of that. And so we are trying not to do that. So just looking at where we are now we would use low-risk medications first. We would use acetaminophen, ibuprofen, etc. for a sports injury. We would never jump to an opioid. There is a purpose to acute pain. It helps you and reminds you not to move too much, to give your body time to rest. We do not treat to a pain level of 0. We do still treat acute pain aggressively because we don't want it to turn into chronic pain, but we're intentional and we taper quickly. We now have a box warning for use of benzodiazepines in conjunction with opioids. And we also now know that prescribed opioids are the gateway drug for our young adults turning to substance use disorders. One of the things that I want to just point out is when you look at the medications that she was on when she came to us, she was being treated for pain, but you can see that she's also on substances that are maybe combating some of the side effects. So the methadone can be sedating, and she's on Adderall as sort of a pick-me-up. She's also on a fairly hefty dose of Xanax, so you know there's an untreated mental health condition. Xanax is really being used just as a Band-Aid for her anxiety. And then this slide is just highlighting some of those medications that Dr. Chamberlin mentioned earlier that can be used for withdrawal symptoms. This patient in particular had had a prolonged withdrawal in the past and was very concerned about that. So what does this look like in the office when you're really working with a patient? This can be an extended, emotional, and challenging process. This is why you need a clear tapering plan with dates at the start of prescribing. So although we didn't start the patient on her current regimen, we did tell her what the end point via a date in the calendar was to meet what she was looking for. She had a really motivating initiative for wanting to come off all of her medications that were legal issues. And she basically self-tapered off her oxycodone, having done it several times before, leaving us to just take care of the methadone. So on this slide, I just want to go over the 5 months of her taper, because I think it highlights a real world example when things don't work perfectly. So in month 1, our directions, we had a means to decrease her methadone down to a dose of 30 to 40 milligrams a day for her total dose. Typically, patients do not have withdrawal symptoms from methadone until they get down to that lower dose. So we were not really worried about the withdrawal symptomatology, just maybe the psychological symptomatology that would go with this, especially given her concern of her past withdrawal. What actually happened was she struggled to get below 50 milligrams total daily dose. So we redirected, looked at her goal, discussed the calendar date so that she's aware that that was not moving. And we gave her a new taper at that time. What happened during month 3 is that she did get down to 45 milligrams of her total daily dose. She was supposed to be down to 40 and then 35, which she did, but then sort of self-titrated back up. So we redirected again when we had an additional appointment with her. We offered several times Suboxone. We highlighted her opioid use disorder, which she felt she could treat on her own. However, in months 4 and 5, she really kept yo-yoing between where she was supposed to be and self-titrating up to where she felt more comfortable. So obviously, it was a challenging discussion, each one of those appointments. And we said at the start of this series that we were going to give you communication skills to assist you with these challenging clinical scenarios, since it's something we really don't learn in training. The Adobe is a great framework that you can switch into as emotions start to run high or the discussion's heating up. It's really trying to drill down to what is the meaning or the real difficulty, the foundational cause of tension, so that you can diffuse it and then set some boundaries. So the phrasing that I used with our Ms. Bloom was, I know it's hard to be worried about being in pain and dealing with the withdrawal symptoms that you've had before and were extensive. You were motivated at the start of this because by getting off your opioids, it rectified some of your legal issues. So how can I help you get to that goal? I want to be cognizant and thoughtful around your symptoms of withdrawal, which we can help you with, but you absolutely cannot self-adjust your dose. We need to consider the component of opioid use disorder, initiate counseling and therapy for that as a means of, if you see there on the E, extending the system to help us out. And we went back and forth with her also about the end date of prescribing, trying to get her to have a plan, and again, extending the system to assist us with this patient.
Another communication style is that 5-step framework we've talked about previously, which is used for many interventions or any intervention or behavior change, from quitting smoking to weight loss or even changing medications. In this setting, the Wasan and colleagues version can be particularly effective, but if you like it, you can really use it at any point in a potentially difficult conversation. So you first acknowledge the problem, Then you allow the patient to vent uninterrupted in a private place. You agree on what the problem is and affirm what can be done. And then you assure the patient that there will be follow-through.
So in the end, Ms. Bloom felt that she really couldn't go below the methadone 35 milligram total daily dose. You know, as a team, we felt like the biggest issue was her opioid use disorder. And I offered her Suboxone treatment several times. Even with all of our boundary treatment, she decided that her goal had changed and she felt comfortable being below the 90 MME based on what her dose was. And she wanted to continue the methadone. So she started seeking out other treatment options. She declined treatment for her opioid use disorder, again, feeling that she could do it on her own. And I'm going to be honest, because of the psychosocial components that sort of tugged a lot at my heartstrings, it was really helpful for me to have other people to keep me honest. So we do this as a team, but having someone in your office as a partner to run the case by is also helpful. It helped keep me in line and not budge from the end date, although I did move it once. She ultimately went off her methadone on her own, and her success, I think, is really to be determined, because what she really needs is opioid use disorder treatment, which she is not willing to do at this time. So we work as a team, which I know seems like we have all these resources that maybe you don't have, but I did want to make you aware of, as we have progressed in our healthcare system, there are new payment models out there, including a collaborative care model where there is embedded psychiatry consultants in primary care offices and vice versa. So Wheeler Clinic has embedded primary care within a behavioral health treatment environment. And working together, we can sort of address these complex cases from a pathophysiology standpoint, but also the psychosocial and psychological standpoint as well.
A big thank you to the Connecticut Department of Public Health, who made this conference and the previous ones possible through the grant funding from Overdose Data to Action. And we look forward to having you and more of your colleagues at the remainder of our seminars, either the redo of this one in a couple of weeks in the evening or the others that we have planned over the remaining year. Thank you. I think we can take questions now.
I'm going to try to, let's see, take our, all right, there we go. So I don't know if anyone has any questions. You can put them into the chat, or there's a Q&A. And I see on screen Dr. Rao, who is the team psychiatrist and addiction psychiatrist, has joined as well. So while we're waiting to see if there are any questions, Sarita, I don't know if you just want to comment on challenges or resources surrounding opioid use disorder. I know we went over a lot of the data now, and misuse is sort of the new disorder, and the literature shows anywhere from 20 to 70% of people on chronic opioids misuse them. I don't know if there's anything that you want to add. I know one of our upcoming talks is going to be about opioid use disorder, but maybe there are some resources you want to share with the participants.
Well, first of all, I want to say it was an amazing presentation. You know, every time I hear both of you speak, I'm just so impressed. So I think one thing I would reinforce from what both of you said is that, you know, it's important to be empathic, but also to kind of gently but firmly hold the frame in place of, you know, that the taper will continue, or, you know, medication agreements, drug screens, all of that other stuff. The one thing that I would say, and of course there'll be a lot more detail about this in my presentation on opioid use disorder later on in the month, in July, is that all of the research starting from the 1970s and 80s, there's so much research that, you know, we don't even like really quote studies anymore unless we have to convince people. But all of the research for the last like 40 years has shown that if you take the population at large, the treatment, the evidence-based treatment that works the best for people with opioid use disorder or addiction to opioids is opioid agonist maintenance therapies, so methadone maintenance or buprenorphine maintenance. But due to social stigma, internalized stigma by patients like Miss Bloom, family pressures, various like myths, people just don't want to go that route. And another reason which people may not express is that there is some underlying resistance, because when you go to a methadone maintenance clinic or you go into um, Suboxone maintenance, buprenorphine maintenance for opioid use disorder, now there are a lot of rules, protocols. They're all designed to help the patient behaviorally move forward, to move away from addictive behaviors into other adaptive coping skills. But if a patient is not internally ready from a stages of change, motivation enhancement standpoint, they may reject it and give other reasons, but it's important to kind of gently reinforce that
Thank
that
you.
is the most optimal treatment. Now,
Thank
this does not mean that an individual patient cannot get dramatically better from going to 28-day rehab or 2-year therapeutic community or Narcotics Anonymous. There are people getting sober every day with these means. But from an epidemiological standpoint, I'm having trouble saying the word, if you look at the population at large, opioid agonist therapies are what's worked, even more than like IM naltrexone.
Thank you. We have a couple of questions, so I'm going to try to keep the answers quicker so that we can get to them. So the first one is, we were asked, how often do we see these patients and how long the appointments are? And so when I do it in the office, the initial appointment, if it's a consult, is 40 minutes, and follow-up are 20-minute appointments, like anything. I would not, unlike what Dr. Rao is talking about with the stigma as far as opioid use disorder, trying to remove the stigma of chronic pain and thinking of it as a chronic disease, really try to like tag your brain to diabetes. So when you put someone on insulin, you might put them on a long acting or short acting and bring them back in 2 to 4 weeks to look at their numbers and then adjust the medication. It's the same thing. So probably 3 to 5 weeks, depending on how anxious your patient is. If they're anxious that a medication, especially before you get to opioids, isn't going to work, sometimes I see them or do a telephone appointment sooner rather than later. There was another question about how to convince or persuade a patient to consider a taper. If they've been stable and on this for a long time, I think it's really good to talk to them about the side effects and the lack of evidence. I can tell you from my practice, I followed my tapers previously. About 30% ended up off opioids because they felt the same but didn't have some of the side effects. 30% went back on at a lower dose, and 30% went back on and hit the same dose they were on. And so where I work at UConn Health now, where I worked before, we tapered people once a year. And the patients were aware that it was going to happen. And so you see this attrition of patients who are on opioids over time. I think just going over the side effects, a lot of males are really actually interested, especially with age, about the gonadal suppression. They have to be aware of that as a downstream endocrinologic effect of their opioid. The other thing is the studies where people have been motivated to taper, they do better. And I guess probably just by telling them that you're not deserting them. You may end up going back on it, but if you're just tapering because they've been stable with no side effects, going over the data that opioids really aren't better and that their higher risk is important, especially when they hit 65. Conversation about diversion, if unable to prove it. So I guess it depends what you have. So I had a patient come in the other day that said a patient I prescribed for is selling. That's hearsay. I have no evidence of it. They obviously know each other outside of the office. That I can't use. If I pull them in for a pill count and all of their medication is gone. And I think that they've sold it because all their medication is gone a week into the prescription, or their UTOX is consistently negative, then I just tell them, like, the way that we are prescribing medication, your urine toxicology should not be negative. It doesn't matter what you're doing with the medicine, and there's no judgment on my part, but I'm not going to prescribe it anymore because it's not in your urine. I'm not doing a slow taper. I'm just not prescribing, but I can come up with a plan for you on pain. It's just not going to include opioids. And, you know, being consistent and calm and persistent in that message, you know, over time, patients do one of two things. They stay with you, which is ideal, because we don't want them going on and starting over with someone else. You have a therapeutic relationship with them, or they leave to search for their opioid, which probably indicates they have either an opioid use disorder or they're diverting as like supplemental income. And I would really rather get to the bottom of that and assist them in a way that I can. It's an uncomfortable conversation. You know, if they have cocaine in their urine and they're using the opioid to sort of supplement the cost of their substance use disorder, like I tell them, it doesn't matter how it got in your urine. I'm not going to judge you for using it. I'm going to offer you treatment, but I'm not going to prescribe the opioid. And then if they have both products in their urine, I just do a rapid taper versus the option of not prescribing at all. I leverage the relationship I have with them to try and keep them in my care, though.
Dr. Andrews and Dr. Chamberlain, I have one more question here. How can patients communicate with you in between appointments if they need reinforcement?
So for us, you know, we have a health portal, just like most systems. We're on Epic, and a lot of them utilize that. I find it helpful, especially if we're going over complicated tapers, to put it into their patient messages, just as another way to do it. They can call the office, just like any patient would get in touch with you for anything. They start on insulin and they have low numbers, they would reach out, and it would be managed partially by staff and partially by the prescribing clinicians. I think we're over time. I just want to make sure there are no other questions. If you do have other questions or you want to hear any of the talk again, we will be doing this in a couple of weeks in the evening as well, especially if it was hard to sign on. I know first thing in the morning when you're getting kids and family out the door can be a challenge. And eventually we will have some PDF slide sets available for the attendees.
Can I just say one last thing, Rebecca and Kevin? So, you know, for the primary care physicians and nurse practitioners on the webinar, you know, buprenorphine is also a good pain medication, but you have to be very careful and document very carefully. You cannot prescribe it for pain when you're you cannot prescribe it for pain while trying to treat opioid use disorder. Those are two different buckets from the DEA, and you can get in a lot of trouble. So you have to prescribe it and document carefully what you're prescribing it for. But in cases of misuse, where you can't really document like an opioid use disorder, putting them on a partial agonist might be helpful. But first you have to do a full taper of the full agonist and, you know, give them like 5 to 7 days in between.
Thanks, Sarita. You know, Suboxone, really, we're trying to normalize its use in primary care. And there are plenty of training sessions for people who have not yet done them. If you're interested, we can also provide you those resources. All right. Thanks, everyone.
Thank you.